Well, good morning, everybody. It's certainly a pleasure to be here. Sue has told me a lot about the Greystone organization, and it's great to be here to learn more about it. And I'm very impressed with what Sue's told me, and also with what I've seen. Picking up on a theme that Rick mentioned, and that's leadership. I'm a student of leadership, wholeheartedly believe that there needs to be huge emphasis on leadership in any organization. And kind of in that vein, one of the main attributes, I think, of a very effective leader is self-awareness. Self-awareness, ability to get input, ability to take that input and modify your skills or further your development as a leader. I'm also a big student of Jim Collins. Collins, the author of Good to Great. We had the opportunity as a management team to go and visit with Collins out in his Boulder, Colorado learning laboratory, which was just fantastic. It could not have been better. And in that experience, one of the things he emphasized was facing the brutal facts, that you really have to face the brutal facts. So in the interest of self-awareness as well as facing the brutal facts, I have to say that our health system, like many others, is perfectly designed and adapted to yesterday's environment, that we really have a real challenge on our hands, that what we have in place is not at all equipped to handle the future of healthcare and tomorrow. And what we're seeing, and what we've seen in the last 24 months, has been a huge amount of change, and it's occurred very rapidly. We've gone from employing 30 physicians to over 300 physicians. And that trajectory looks like we're going to be up to 500 by within another 24 months. We've taken about $60 million in cost out of our system over the last 24 months and recognize we've got to take a lot more out to really be successful. We've had 5 hospitals approach us to be partners or to merge into our system, which we're continuing to examine. And very pertinent to today's topic, we really have entered into significant dialogue with many post-acute care facilities and CCRCs, knowing that if we don't get that right, we really aren't going to be successful for the future. So what is driving this change? Well, let's take a look at it, and we take a look at it with or without reform. I mean, the fact that the ACA has been deemed to be a piece of legislation they're going to leave in place is something Pam's going to cover. But with or without the ACA, we are facing some pretty radical changes. And I know most of you are aware of a lot of these things, but it's clear federal and state budgets aren't going to get a lot healthier. There's going to be continued pressure to really keep reimbursement flat or bring it down. Commercial cost shifting is going to be limited. I know in our system we have about $1.4 billion in revenue. We lose about $100 million in Medicare, Medicaid, and private pay or indigent care. And we try to make about $100 million, which is about a 3% margin. So we are cost shifting basically $200 million onto the commercial payer. That's probably the biggest hidden tax in America right now, is the cost shifting that's occurring in the acute care side of the business, and I'm sure it's probably true in the post-acute too. Continuing cost pressures are huge. You know, when you look at pharmaceutical costs, medical device costs, new technology, we're facing for the next 5 years, probably a 1 to 2% revenue growth and a 4 to 6% cost trajectory. So that's a big gap to fill on, again, $1.4 billion in revenue. And that's a challenge for us, for sure. And then the shift in payer mix, which makes things even more challenging. So we're seeing more and more government pay patients. And I'll cover that in more detail in just a second. And then we've got a deteriorating case mix. We have many more chronically ill patients. We have many more medicine patients. We have patients that demand ICU care, and that is kind of squeezing out the more profitable side of our business. So on the demographics, they are reshaping the payer mix, and if you look at this information from the Healthcare Advisory Board, you can see that from 2011 to 2021, we're looking at a significant shift into more and more government payer categories. So Medicare shifts the most significantly from 37% to 52%. And again, this is for acute care providers. Medicaid goes down a little bit, and commercial goes down significantly from 35% to 27%. And you can see as a result of the Affordable Care Act, we're looking at self-pay shrinking significantly. I think that is very optimistic. There's still going to be over 20 million uninsured in the United States. But this is the projections from the advisory board that we're using for our future forecasting. And as you shift to more Medicare, you can see you have more intensity in terms of resource consumption. So on the inpatient side, Medicare, their inpatient services demand 3 times the overall resource consumption that any other payer category demands. So we are transitioning from an economic structure that's built on volume to one that's built on value. We've been chasing revenue for decades now in the fee-for-service business, and now we're trying to move that to, and the payers are moving us to, value-based purchasing. On October 1st of this year, Medicare will be paying us on performance related to clinical quality measures as well as HCAP scores, which are the patient experience measures. We do have requirements that are being developed, and you guys, I'm sure, are familiar with them for the post-acute care environment. Our 30-day readmission penalties hit us on October 1st, 2012, and that 30-day penalty can go up to 1% of your overall Medicare reimbursement, which in our case is about $5 million a year. So it's not insignificant, and it's something that we're paying a lot of attention to and working with our post-acute care providers to help us manage much more effectively. And then bundle payments. There is a national Medicare pilot program on bundle payments. It's still, again, in development, but January 1st, 2013 is when they plan to roll it out. So we're deeply involved in that. We do have an accountable care organization, and we are working with Blue Cross, Cigna, United, and other payers in our market to implement pilot programs. We have a number of them, but I will tell you that most of the payers really have fairly minor experiments in this. I mean, I think generally the payers are making really good money. They don't see a burning platform to shift their models in terms of reimbursement realignment very quickly, but they do get the message that they're going to have to do this sooner or later, and that they better start learning more about it as we go forward in this environment. So, what changes are occurring and why? Well, in the post-acute area, I won't go over all this. I know you all are familiar with it, but certainly in the CMS world, they're continuing to try to curtail spending, and they're doing it pretty effectively, especially when you look at SNFs. And we do have a skilled nursing facility, and we are trying to manage through this. And we also have home health care, and we're trying to manage through that. And that's not easy in light of some of the measures that they're taking and will continue to be taking into fiscal year 2013. What's likely to happen next? Well, on that list on the right side of the slide, you can see they're going to continue to pay increasing attention to variability, to fraud. We can expect the number of quality measures that they're looking at to increase. They're going to demand a lot more transparency, not just CMS, but also any of the payers. And we're deep into that, especially with Blue Cross in the Tennessee markets. And telemedicine is a real opportunity, and I think that's something that all of us need to work more on. Reimbursement for that is a challenge, but I think it's something that could be extremely effective for both the acute care as well as the post-acute care environment. Post-acute care is real important to us. About half of our patients are discharged to post-acute care providers, and you can see how that maps out here on this slide. Now these again are Medicare patients over the age of 65, but you can look at the breakdown here. So as we think about transitions in care, addressing length of stay, doing other work in our quality measures, we have got to have post-acute care providers that are true partners with us. And that's where our success is going to be found. It's going to be found in collaboration to mitigate performance risk. Our assumption, and I think this is a realistic one, is that we will be at risk for the majority of the care that's provided sooner or later. We are not going to get into the insurance business. That's not our strategy, nor are we going to get into the post-acute care business. But we do know we've got to have a footprint that does enable us to take risk. And that means forming partnerships with CCRCs and post-acute care providers that enable us to do just that. So it's the clinical integration that's key. It's the doctors and identifying clinical pathways, identifying ways to reduce the huge variation in care today. And I know you all see it. We are particularly keenly aware of it on the acute care side. As we buy practices, we bought a cardiology practice about a year ago. There are 18 cardiologists in it. No one cardiologist practice is the same or for the same disease process. I mean, there's such variability out there. That's the real opportunity, I think, and when you look at clinical utilization and clinical utilization management for the future. And post-acute care providers, enabling that effective transition is, again, really key, and obviously patients. We're embracing patient and family-centered care. It's part of our culture, and whoever we partner with, we expect them to embrace that strategy and strategic initiative as well. And patient education is also key. So over the last year especially, but 2 years, we really have been rethinking our relationships across the care continuum. And on pre-acute care, the one thing I'll mention there that I haven't already mentioned is we now have partnerships with 450 congregations in Memphis, recognizing that congregations, that churches could be a real asset for us as we think about population health and impacting the health status of people in any community. And on the inpatient acute care side and the post-acute care side, you can see some of the things we're looking at and the areas of focus for us. So we do realize the value of partnering across the care continuum, and as I said, our feeling is and assumption is that we're going to be increasingly responsible for the care of patients pre and post-acute care. So we have formed a post-acute care collaborative about 24 months ago. We are developing agreements with many of our post-acute care partners, and what we're looking at there is smooth information exchange that results in better continuity of care, which we haven't had, frankly, in the past. We have an electronic medical record. Our platform for the clinical enterprise is Cerner, and we're now putting access in many of our post-acute care partner locations to the electronic medical record in a look-only phase, but it is already paying some dividends. We are participating jointly in clinical education sessions, and we get as much value out of those as I think our post-acute care partners do. We are seeing some impact on reduction of readmissions as a result of our joint work. And we jointly agree upon quality measures. Some of them are readmission rate, UTIs per 1,000, decubitus rates, ODE mortality, a number of them that we mutually agree upon and we really hone down on, create clinical teams to work on, and again, we're getting some good traction. And our commitment to them is multifaceted, but primarily we give 24-hour notice of discharge and try to have really good, smooth coordination. So when we look at patient care from a patient and family-centered care standpoint, we realize that who we want to partner with are the best and the highest quality partners that we can find to be a part of the continuum. U.S. News and World Report just came out and ranked us #1 in our region, and we want to align with partners who can help us continue to build on our reputation of high quality. We're obsessed with improvement. We expect our partners to be. We try to be agile, although with 11,000 employees and 2,000 doctors, we are a big bureaucracy, and sometimes that agility is tough to achieve. But we also embrace a culture of transparency. And again, that's an expectation of any of our partners. Yeah, I'm really optimistic. I really am. I mean, I think we all have an opportunity to reshape healthcare and make it much better for patients and families. And this opportunity in my 35 years in healthcare is real for the first time, and it's happening. So I do think we need to seize the opportunity, work collaboratively together, and truly make some change that will be significantly better for our nation and our patients and our families. I'm going to look forward to answering any questions, and at this time I'd like to bring up Pam Landsman to do the next phase of our presentation.